Good day everyone, I'm Ezekiel Rosales. So today we will discuss what is combined B cell and T cell disorders.
In this discussion, we will talk about the definition of combined B cell and T cell disorders, its etiology, pathophysiology, signs and symptoms, complications, diagnostic and laboratory procedures, treatment, nursing diagnosis, nursing responsibilities, and prognosis. First, let's define what is B cell and T cell disorders. What are B cell and T cell disorders? T cell and B cell immune disorders comprise a heterogeneous group of disorders, all characterized by profound impairment in the development of function of the cellular, the humoral, or both parts of the immune system. A variety of inherited, autosomal recessive, and X-linked conditions fit this description. These conditions are typified by disruption of normal communication system of B cells and T cells, and impairment of the immune response, and they appear early in life. The most common combined B cell and T cell disorders are ataxia-telangiectasia, severe combined immunodeficiency diseases, and Wiskott-Aldrich syndrome. First, let's discuss about severe combined immunodeficiency disease, or SCID. I prepared a video about it on the next slide, so please watch it so that you can understand what is its process, treatment, and complications.
Hi, I'm Franco. I hope this lecture finds you well. I'm the fruit of Ezekiel's imagination. So I was tasked to report on severe combined immunodeficiency syndrome, or SCID. So again, SCID is an inherited format of immunodeficiency where T cell and B cell mediated immune response are absent or lacking. First of all, this disease resulting from absence of T cell or maybe lack or impairment of T cell function. Also B cell mediated antibody responses could also be defective, that means cell mediated immune response and the humoral immune response, or both arm of the immune response is compromised. Now severe combined immune deficiency results from genetic defects that leads to absolute lack of T cells in the peripheries. Cause, generally T cells are circulating in the peripheries, but in these diseases T cells or the circulating T cells are literally absent. Why these T cells are absent? They are absent because these defects, which are at genetic level, they target or they occur in the very early stage of the T cell development, or they affect the stem cells that feed the lymphoid lineage. So, these are the two defects that happens in severe combined immunodeficiencies. First, there could be defect in cytokine signaling, caused by mutations in certain cytokines, cytokine receptors, or regulated molecules that control their expression. Cytokine signaling is very important for T cell, B cell, or any kind of immune cell development. So, we know cytokines binds to cytokine receptors on the T cell precursors and ultimately give it the proper instruction to differentiate into a mature T cell. Now in absence or in the case of mutation in these components, which might be a mutation in the receptor or intermediate signaling players or transcription factors, these particular mutation in these cellular components might lead to maturation defect of the T cells, which ultimately reduce the number of circulating T cells. Premature death of the lymphoid lineage is also reported in case of SCID. Most of the cases, toxic metabolites of purine biosynthetic system accumulate, which leads to destruction of these early or immature T cells. Secondly, defective VDJ rearrangement in developing lymphocytes, caused by mutations in gene for RAG1 and RAG2, or other proteins involved in rearrangement process. Now defective VDJ recombination was found to be a cause of SCID, in VDC recombination which occurs in the TCR gene, and there is one particular enzyme which is a product of RAG1 or recombination associated gene, so these RAG1 and RAG2 recombinases are crucial for VDG recombination, but in many cases it has been seen that RAG1 or RAG2 genes are mutated. As a result, VDJ recombination does not happen, and these T cell or the TCR receptor, they lack diversity. That is another cause of SCID. Now there could be disruption of pre-TCR or TCR signaling during development caused by mutations in tyrosine kinases, adapter molecules, downstream messengers, or transcription factors involved in TCR signaling. T-cell receptors, once it interacts with MHC molecules, it gives rise to several signaling cascades, and many components of these signaling cascades might be mutated in case of SCID. Now SCID is not caused due to one particular reason, there could be plethora of reasons whose end result is SCID. Now depending upon the underlying genetic factor, an individual with SCID might have total loss of T and B cell, or it might have loss of only T cells but there is B cell present. Now even if B cell is present, these B cells would not undergo somatic hypermutation or affinity maturation, because all these processes require T-cell mediated B cell activation independent, or T-cell independent B cell independent activation, which does not lead to these processes. So even if there is some amount of antibody mediated responses, it would be ultra weak, and mostly non-specific. So in the first place we can see, cell mediated immunities totally compromised, and humoral immunity would be partially compromised, and in the next case, where both the T cell and B cell are absent, both cell-mediated and humoral immunity would be compromised. So, T cell help B cell to get activated, and this activation is pretty strong, and this signal ultimately tells the B cell to perform somatic hypermutation, or undergo class switching, to produce different isotypes of antibody. But these does not happen when there is T helper independent B cell activation, so that is why we understand in SCID, there is some amount of antibody responses that is very weak and non-specific. So, this T cell mediated and B cell activation ultimately lead to class switching, and this class switching requires an enzyme known as AID. Now it has been seen that AID is mutated, or not functional, in case of SCID patient, but how to understand if SCID is happening in the patient? So, first of all, there could be very low number of circulating lymphocyte. Secondly, there would be failure to mount an immune responses mediated by T cells. In many cases, the thymus will not fully develop without a sufficient number of T cells. Now, the infants with SCID experience severe recurrent infections, that, without early aggressive treatment, it could prove to be fatal. That means normal child are kind of immune to several bacteria and viruses that might harm him, so the body generally knows how to deal with it. But since the immune system is severely compromised in SCID, these pathogens, which are not actually threat from a baby, it would be now proved to be harmful. The situation is so bad that the newborn or infant with SCID can suffer from chronic diarrheas, respiratory infections, and have problems in the life. So that is why they have to be kept in an isolated environment which is germ-free. Now in case of SCID, the situation is so much compromised that even if you provide attenuated vaccines, that vaccine might lead to infections in these babies, so it's pretty detrimental. Now there are several screening tests by which SCID can be detected. One way to understand is to see VDJ recombination is happening or not. If VDJ recombination happens, then mature TCR and VCR will be formed, so obviously, the lariat which would be excised during VDJ recombination, should be detected if the TCR and VCR maturation is proper. If they are not detected, that means TCR and VCR development is compromised and there could be defect. Now deficiency in cytokine signaling is at the root of most common forms of SCID. Several cytokine receptor or cytokine receptor mediated signaling is compromised. For example, if we talk about IL-2 receptor, IL-3 receptor gamma is actually mutated in SCID patients, so obviously, IL-2 receptor mediated signaling is compromised. Now this IL-2 receptor gamma is actually encoded by X genes, X chromosomes, so obviously it is an X-linked SCID and it is more prevalent in males. Next, let me tell you that these IL-2 receptors are actually county receptor of several interleukin receptors such as IL-4, IL-7, IL-15 etc. So obviously, IL-7 is really important for B cell development, whereas IL-2 is important for NK cell development, so in absence of IL-7, in absence of IL-7 mediated signaling or IL-15 mediated signaling, NK cell and B cell signaling could be abrogated. So immune system would be compromised in various ways. Now, AID deficiency is another important cause of SCID. We have already discussed that AID is important for somatic hypermutation and class switching, which are all B cell maturation process. Ultimately, this whole causes of SCID boils them to T cell and B cell maturation, or developmental process, and majority of the cases, B cell and T cell development is abrogated, or T cell or B cell levels are low, their circulating numbers are low, etc. So lastly, we need talk about some important facts of SCID, that in most instances the genetic defect associated with SCID might lead to reticular dysgenesis, it might alter hematopoiesis, and it can also affect the inner cells as well derived from myeloid lineage. Now MHC defects sometimes can resemble SCID-like phenotypes, but not necessary. MHC defects give rise to SCID. Now the treatment options that is available for SCID right now, is bone marrow transplantation, but the success rate is not so high, but increases chance of survival, so I hope in this video we get comprehensive overview about SCID. Thank you for listening. That would be the overview of severe combined immune deficiency syndrome or SCID. Once again, I'm Franco. I hope this discussion finds you well. Sounds familiar? Again, I'm a fruit of Ezekiel's imagination. All info are prepared and given by him. All credits to brother HAHA ha 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 ha. Tots 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 tots, low battery, shutting down.
SCID is a pediatric emergency. The most common curative therapy for all forms of SCID is bone marrow transplantation from HLA identical or haploidentical donors. Without this, death usually occurs by 1 year of age and invariably before the patient's second birthday. No chemotherapeutic conditioning is required to achieve engraftment because the recipient is devoid of T cells at the time of transplantation. Some patients with EDA deficiency may be treated with enzyme replacement therapy. However, most receive transplant. And the last, gene therapy has been on the horizon as promising treatment for SCID. However, serious adverse events including development of leukemic-like processes in treated infants have halted its progress.
Laboratory diagnosis of SCID requires evaluation of humoral and cellular immunity. Studies include the absolute numbers and percentages of lymphocyte subsets such as TB and NK, measurement of immunoglobulin levels, and assessment of T cell function. At the age of 6 to 7 months, when most infants with SCID are diagnosed, the normal absolute lymphocyte count is high, and any count less than 4,000 cells per cubic millimeter is lymphopenic. Flow cytometry and T cell function studies should be performed to further evaluate lymphopenia. T cell function is usually determined by measurement of responses to mitogens such as phytohemagglutinin and concatenavalin A. A diagnosis of SCID is made if the absolute lymphocyte count is less than 2,500 cells cubic millimeter. T cells make up less than 20% of the total lymphocytes and the response to mitogens is less than 10% of the control. For the list of imaging techniques, chest radiograph of infants with SCID is notable for absence of the thymic shadow. Patient with EDA deficiency variant of SCID will have other skeletal abnormalities on radiographic examination, including chondro-osseous dysplasia, with flaring of the costochondral junctions and a bone-in-bone anomaly in the vertebral bodies.
Next disease will be the Wiskott-Aldrich syndrome. What is Wiskott-Aldrich syndrome all about? Wiskott-Aldrich syndrome is an X-linked defect occurs in Wiskott-Aldrich syndrome protein or WASP, causing cellular defects in actin cytoskeleton. This affects all the hematopoietic cells, especially platelets and T cells. T cells lose the ability to stimulate B cells in response to capsular polysaccharides. present is some bacteria. Without treatment, most patients do not live beyond adolescence. Presentation of Wiskott-Aldrich syndrome. Pyogenic infection, bleeding diastasis, and eczema. Affected individuals also have increased incidence of autoimmune disorders and lymphoma. Diagnosis of Wiskott-Aldrich syndrome include low normal levels of IgG and IgM, with elevated levels of IgE and IgA, and abnormally small platelets and peripheral smear. Treatment is bone marrow transplantation. Wiskott-Aldrich syndrome. The mnemonic is water. Wiskott-Aldrich, thrombocytopenic, purpura, eczema, and recurrent infections. Wiskott-Aldrich syndrome is most often seen in young males presenting with immune deficiency, eczematous dermatitis, and microthrombocytopenia. Thrombocytopenia may manifest bleeding, petechiae, purpura, gastrointestinal bleeding, epistaxis, hematuria, and or life-threatening hemorrhage. Patient may also present immune deficiency that may manifest recurrent infections due to impaired T and B cell numbers and function. Severe infections with encapsulated bacteria may occur, and splenectomy performed for thrombocytopenia will worsen this propensity to infection. Opportunistic infections can also be seen. Fungal infections are more rare. Eczematous dermatitis is common and may be observed, and autoimmunity is present as many as 70% of patients. Malignancy is also observed, most commonly B-cell lymphomas associated with Epstein-Barr virus. Patients diagnosed with Wiskott-Aldrich syndrome receive prophylactic treatment for frequent infections. This may include intravenous immunoglobulin therapy for patients found to be antibody deficient. Prophylactic antibiotic therapy with trimethoprim, sulfametazole, and aciclovir should also be used. Platelet transfusions may be necessary for bleeding manifestations. Splenectomy has been recommended in the past for thrombocytopenia, but is no longer recommended because of the increased risk of infection with encapsulated bacteria. Immunosuppressive therapies such as rituximab may be used for autoimmune disease. However, the risk of infection must be carefully considered. Hematopoietic stem cell transplant is the only definitive treatment for Wiskott-Aldrich syndrome. Gene therapy for Wiskott-Aldrich syndrome is currently under investigation and is not yet used in clinical practice. When will a person with Wiskott-Aldrich syndrome get hospitalized? First, when a patient presents thrombocytopenia and or severe infections and associated complications that require immediate hospitalizations, and hospitalization should occur in tertiary care institution with access to physicians familiar with the disease, as well as immunologists, pediatric intensivists, and other pediatric specialists. List of diagnostic tests for Wiskott-Aldrich syndrome include CBC with differential, T-cell number and functional studies, B-cell number and functional studies, NK cell number and functional studies, immunoglobulin levels, and sequence of Wiskott-Aldrich syndrome gene necessary to confirm diagnosis. Last but not the least is the ataxia telangiectasia. So what is ataxia telangiectasia?
Ataxia telangiectasia is an autosomal recessive disorder that results in a mutation of chromosome number 11 in ATM gene. The ATM gene provides instructions for making a protein that is located primarily in the nucleus of the cells, where it helps control the rate at which cells grow and divide. Now, do you have any idea what ATM gene is? The gene product in ATM gene is mainly involved in sensing DNA that has been damaged by radiation. What exactly the ATM gene will do? ATM gene is responsible for synthesis of a product or a protein. We can say a gene product of the ATM gene. To repeat it again, the gene product of the ATM gene is involved in the process sensing the DNA that has been damaged by the radiation. So once there is a radiation-induced DNA damage, then immediately, the DNA damage is detected by the gene products by which are produced by the ATM gene. Then, it signals the p53 to delay the cell cycle and allow for a DNA repair. But before we proceed, what is p53? p53 is a protein that acts as tumor suppressor, which means that it regulates the cell division by keeping cells from growing and dividing too fast or in an uncontrolled way. So now let's continue. Right after, the gene product of the 18 gene after detecting the DNA damage by radiation, it signals the p53 and asks the p53 to delay the cell cycle so that they have the time for the DNA repair. If the DNA gene is mutated, the p53 is not activated. And if the p53 is not activated, the cell cycle continues without DNA repair that is damaged. A DNA repair mechanism cannot happen, so allowing the replication of the damage of the DNA itself. The replication of the damaged DNA leads to an abnormal cellular development, especially in the neurologic, vascular, and the immune system. So the major clinical manifestations of ataxia telangiectasia is neuronal, neurologic, vascular, and immune. When we are talking with the neuronal, the neurons of the cerebellum, especially in the Purkinje layer, granular layer of the cerebellum, are more commonly involved. So the reason cerebellum is particularly affected. And a pathological examination of the cerebellum reveals loss of Purkinje and the last granule cells of the cerebellum, which is responsible for the development of ataxia. The clinical manifestations of ataxia telangiectasia is that it usually presents in the early childhood. Ataxia generally starts from later 24 months and it is more prominent by the age of 3 years. Then there will be telangiectasia of the face as well as conjunctiva, cerebellar ataxia plus various immune deficiencies. Then these various immune deficiencies can lead to recurrent respiratory infections. In addition, there will be an endocrinologic abnormality such as growth retardation, reproductive dysfunction, and diabetes. So these are the things that you need to know about the clinical manifestations of ataxia telangiectasia. And what are the complications? There is a very high degree of predisposition of developing cancers, especially breast, lymphoma, and leukemia. And the lymphomas and leukemias are more commonly present in pediatric group, very rarely the breast one. For the treatment, the first line of therapy are vitamin A combined with folic acid supplementation. Vitamin A and folic acid supplementation is antioxidant, and avoid radiation if possible. Most patients of this case do not live past 25 years or many died much earlier. Majority died 14 to 15 years old. The reason I said breast cancers of babies are rare and is mainly seen in the patient with age 25. So there is a reason in lymphomas and leukemias are more commonly present by approximately 24 months. So these are the age of ataxia telangiectasia.
A major nursing diagnosis for the aforementioned combined B-cell and T-cell disorders include risk for infection related to impaired B-cell and T-cell function, impaired skin integrity related to pathogenic infections, social isolation related to disease process, and acute pain related to infections. For the nursing responsibilities of this condition, first, monitor for signs and symptoms of infection. Signs and symptoms of infection vary according to the body area involved. Redness, swelling, increased pain, purulent discharge from incisions, injury and exit sites of tubings, such as drains or catheters, these are the classic signs of infection. Any suspicious drainage should be cultured so that antibiotic therapy is determined by pathogens identified. Next will be elevated temperature. The temperature up to 38 degrees Celsius or 100.4 degrees Fahrenheit 48 hours post-op is usually related to surgical stress. After 48 hours, a temperature of greater than 37.7 degrees or 99.8 degrees Fahrenheit may indicate infection. Very high temperature accompanied by sweating and chills may indicate septicemia. Next will be assessed for the color of respiratory secretions. Yellow or yellow-green sputum is indicative for respiratory infections. And the last, appearance for urine. Cloudy,
Turbid or smelling urine with visible sediment is indicative of urinary tract or bladder infection. Next, nursing responsibilities is to maintain strict assessment for dressing changes, wound care, intravenous therapy, and catheter handling. Aseptic technique decreases the chances of transmitting or spreading pathogens to or between the patients. Interrupting the chain of infection is an effective way to prevent the spread of infection. Then, ensure that any articles used are properly disinfected or sterilized before use. This reduces or eliminates germs. Next will be wash hands or perform hand hygiene before having contact with the patient. Also impart these duties to the patient and their significant others. Know the instances when to perform hand hygiene or 5 moments of hand hygiene. First, before touching a patient. Second, before clean or aseptic procedures such as wound dressing, starting an IV, or etc. Third, after body fluid exposure. Fourth, after touching a patient, and the last, after touching the patient's surroundings. Washing and running water effectively removes microorganisms from hands. Washing between procedures reduces the risk of transmitting pathogens from one area to another. Wash hands with antiseptic soap and water for at least 15 seconds followed by alcohol-based hand rub. If hands were not in contact with anyone or anything in the room, use an alcohol-based hand rub and rub until dry. Plain soap is good at reducing bacterial counts, but antimicrobial soap is better, and alcohol-based hand rubs are the best. Educate clients and significant others about appropriate methods of cleaning, disinfecting, and sterilizing items. Knowledge of ways to reduce or eliminate germs reduces the likelihood of transmission. Next nursing responsibilities is to encourage intake of protein-rich and calorie-rich foods. Proper nutrition plays a part in supporting the immune system's responsiveness. Next nursing responsibilities is to perform measures to break the chain of infection and prevent infection. The following methods help break the chain of infection and prevent conditions that may be suitable for microbial growth. Number 1. Change dressing and bandages that are soiled or wet. Number 2. Assist clients in carrying out appropriate skin and oral hygiene. Number 3. Dispose of soiled linens properly. Number 4. Ensure all fluid containers are covered or capped. Number 5. Avoid talking, coughing, or sneezing over open wounds or sterile fields. Number 6. Wear gloves when handling patients' secretions. And number 7. Instruct clients to perform hand hygiene when handling food or eating. Encourage increase in fluid intake unless contraindicated, such as heart failure and kidney failure. Fluids help promote diluted urine, frequent emptying of the bladder, and reduce the stasis of the urine. This ultimately reduces the risk of bladder infection or urinary tract infection. Encourage adult patients in coughing and deep breathing exercises, and do frequent position changes. It helps reduce the stasis of secretions in the lungs and bronchial tree. When stasis occurs, microbial infection of the respiratory tract occurs and may lead to pneumonia. Then recommend the use of soft bristled toothbrushes and stool softeners to protect mucous membranes. Hard bristled toothbrushes can compromise the integrity of the mucous membrane and provide a port of entry for pathogens. Other nursing responsibility of the nurse is to limit visitors. Restricting visitation reduces the transmission of pathogens. Then, provide surgical masks to visitors who are coughing and provide rationale to enforce usage. Instruct visitors to cover mouth and nose by using elbows to cover during coughing or sneezing. Use of tissues to contain respiratory secretions with immediate disposal to a no-touch receptacle, and perform hand hygiene afterward. Educating visitors on the importance of preventing droplet transmission from themselves to others reduces the risk of infection. Next nursing responsibility is to place the patient in protective isolation if the patient is at high risk of infection. Protective isolation is set when the WBC indicates neutropenia. More importantly, wear personal protective equipment or PPE properly. For the gloves, wear gloves when providing direct care and perform hand hygiene after properly disposing gloves. For the masks, use masks
goggles, face shields to protect the mucous membranes of your eyes, mouth, and nose during procedures and indirect care activities such as suctioning secretions that may generate splashes or spray of blood, body fluid secretions, and excretions. And for the gowns, wear a gown for a direct contact with uncontained secretions or excretions. Remove gown and perform hand hygiene before leaving the patient's room or cubicle. Never use gowns even with the same individual. Other nursing responsibilities include teach the importance of avoiding contact with individuals who have infections or colds and teach the importance of physical distancing. Other people can spread infections or colds to a susceptible patient, such as immunocompromised patient, through direct contact, contaminated objects, or through air currents. Demonstrate and allow return demonstration of all high-risk procedures that the patients and/or the significant others will do after discharge, such as dressing changes, peripheral or central IV site care, and so on. Patient and significant others need opportunities to master new skills to reduce risk for infection, so the nurse must teach the patient, family, and caregivers the purpose and proper techniques for maintaining isolation. Knowledge of isolation can help patients and family members cooperate with specific precautions. If infection occurs, teach the patient to take anti-infectives as prescribed. If taking antibiotics, instruct patient to take the full course of antibiotics even if the symptoms improve or disappear. Antibiotics work best when the constant blood level is maintained, which is done when medications are taken as prescribed. Not completing the prescribed antibiotic regimen can lead to drug resistance in the pathogen and reactivation of symptoms. Advise these patients to avoid excessive sun exposure and to use sunscreens when outdoors. Because of the increased sensitivity to radiation in patients with ataxia telangiectasia, advise these patients to avoid excessive sun exposure and to use sunscreens when outdoors. Instruct to avoid additional risk factors such as smoking and drinking alcohol. Alcohol and smoking suppresses the immune cell function of the T cells or B cells. Then, administer immunosuppressive drugs as prescribed to ensure engraftment of depleted bone marrow during transplantation procedures. Then, administer and teach the family the importance of proper oral hygiene to prevent dental caries, which is the source of secondary infection. Other than that, administer and teach the family about good skin care. A break in the skin is a source of secondary infection. And lastly, teach the family the importance of safe food preparation, including use of safe water to avoid introducing pathogens through contaminated or undercooked food. The prognosis of ataxia telangiectasia are the following. Because the underlying immune deficiency in patients with ataxia telangiectasia widely varies, overall prognosis can vary. Approximately 10 to 15% develop malignancy in childhood, usually lymphoid tumors. However, other tumors including brain tumors and certain carcinomas have also been seen in patients with AT. The role of ATM mutations in breast cancer is currently under intense investigation. Similarly, the degree and extent of any associated autoimmune endocrinopathies in patients with chronic mucocutaneous candidiasis widely varies and affects the prognosis. Early detection of malignancy and aggressive treatment for sinopulmonary infections prolong survival. In AT, their chronic lung disease appeared to be primarily interstitial and responsive only to systemic corticosteroids given early in the course. One case report detailed improvement of neurologic symptoms with systemic corticosteroids. For the prognosis of severe combined immunodeficiency, or SCID, without treatment, infants with SCID usually die from infections within the first 2 years of life. With an early bone marrow transplant, frequent follow-up and treatment for infections, survival rates are very good. A survey of more than 150 patients commissioned by the Immune Deficiency Foundation found that SCID patients who were diagnosed early and treated by 3.5 months had a 91% survival rate. Those treated after 3.5 months had a 76% survival rate. Scott-Aldrich syndrome,
Long-term prognosis was poor in the past. Prior to use of stem cell transplantation, few patients survived beyond their teens and most succumbed to complications of bleeding, infection, or malignancy. Median survival in a cohort of patients born after 1964 was 6.5 years, although survival rates have continued to increase over time. With aggressive care, prognosis have substantially improved. One study projects median survival of 25 years for patients who undergo splenectomy and even longer for patients who undergo successful bone marrow transplant. Success rates of all categories of stem cell transplantation have continued to climb over time. From the most recent series of transplanted patients, overall survival from HSCT was approximately 90%. And that would be all, everyone. Thank you for watching, and I hope you learned something about the discussion. Thank you.